So good morning, and this is a presentation that I've done for the European course of Pediatric Neuroradiology, the virtual edition in January 2021. And I would like really to thank very much the organizer for inviting me. It's a big honor for me to be here. I will be speaking on pediatric CSF, hypo, and hypertension, and all the important findings for the radiologists. Just one thing, my lectures are on YouTube, so if you are interested, please check my channel out. And let's start with learning objective. I will show you how to do a diagnosis of CSF hypo and hypertension. There are evidences, but also controversies. And I will stress the specific issues in pediatric population. Also, we'll show you some right protocols, pathogenesis, and pitfalls. So let's start with the hypotension. That is indeed a fascinating topic. Most of the literature is in the adult, but this is a pediatric course. Let's start with the pediatric case. This is a 14-year-old male with orthostatic headaches and neck pain. Very important in both hyper and hypotension to look at the clinical context, and a background of Gorham-Stout disease and spinal fixation because of the Gorham-Stout disease. Now, as always happen in pediatric population, there are a lot of complex genetic and rare disease. So every time you need to first know what you are dealing with, and in this case, what is Gorham disease or vanishing bone disease is actually progressive or osteolysis with abundant vascular and lymphatic proliferation. So basically the bone is replaced by fibrous tissue, and what you have is something like that. You can see here a lot of areas of osteolysis where there should be bone, and then enhancing fibrous tissue. Let's come back. So this is Gorham-Stout disease. Let's come back to our case. So this is a teenager with orthostatic headaches and neck pain, previous spinal fixation due to the problem related to Gorham-Stout disease. But actually, let's look at the brain. And remember, in these cases, like most of the cases in pediatric neurology, there are a lot of single findings that may be non-specific or even sometimes paraphysiological, but look at the constellation of findings. This helps you a lot in the diagnosis. So let's see this brain and let's see what are the findings. First of all, the cerebellar tonsils are a bit low. These are non-specific findings. It depends by the cause, as you saw yesterday on Saturday. But in this case, they are definitely low. So we keep that in the back of our mind. Narrow cistern and so-called fat or flat pons. Here you see the crowding of the posterior fossa in general. And there is a relatively bulky pituitary gland in comparison to what is expected on a male at this age. Female can be like that physiologically, but for a male, probably too much. And look, very important, the enlarged venous sinuses. So there is this bulging of the venous sinuses. So this is basically a scan for headache, but it's a specific kind of headache. It's a specific clinical context. Our working diagnosis, this is a scan I saw at the Evelina. So I say, oh, this may be intracranial hypotension. But in the clinical history, only for headache, we didn't give contrast, but actually contrast may add something to this working diagnosis. So before to show you a contrast, let me show you the difference, as I say, between the patient and an age-matched control here. So you can see the relatively bulky gland. What is missing? It's missing the contrast, and in fact, in patients with intracranial hypotension, and I will show you in a bit why is that, you have a thickening of the dura that you can see with contrast, and in rare cases, especially in children, it's very, very rare, you can have actually subdural collection. So now you have all the findings related to intracranial hypotension, which we'll repeat in a bit, but let's look for the cause of the intracranial hypotension, so CSF hypotension. The cause of the CSF hypotension is actually most of the time a CSF leak. In this case, we have a cause for CSF leak, so this is not a so-called idiopathic intracranial hypotension that, as I will show, also will have this kind of leak as a cause, but in this case, there was clearly It's a problem related to the fixation, and you see this epidural fluid collection. So this is a secondary intracranial hypotension due to a complication of a fixation. And in general, even in the cases that before were called idiopathic, we have evidence of CSF leak. They can be high flow leak or slow flow leak, but you will have often, not all the times, but often this epidural fluid, increased epidural fluid. So remember that if you use only MRI, that is the case in children, you can do a diagnosis of intracranial hypotension based on images of the brain that I show you and the spine with the epidural fluid, but you cannot precisely identify the location of the leak. So that's my pearl when you use MRI. That's very important. But do we really need to identify a leak? Actually, no, because most of the time a non-target therapy works, and you don't want really to irradiate the children doing a dynamic myelography in all the cases, so only in selected cases. But why you have this summary of images that I showed you before in these children with CSF hypotension? The reason is the Moron-Kelly hypothesis that says that the volume of brain, blood, and CSF must remain constant. But in this case, we are losing CSF. So we have a CSF leak, and we saw that sometimes we see this leak as an epidural collection in the spine. But what we see in the brain? Well, we have the compensatory effect of the brain. So we have this crowding of on the posterior fossa structure and of the pituitary gland, compensatory effect of the blood. So the volume of the blood increases, so you have enlargement of the sinuses. And also, if you give contrast, you will see compensatory effect of the dura. So basically, and in the advanced cases, the subdural fluid. So basically what you have is an explanation of this constellation of findings that I showed you before. That is very, very, very important. So remember though that you need the right clinical context, and you need also to understand that headaches are often, but not always, orthostatic in this patient. So because the diagnostic criteria are very important, this is the classification, the diagnostic criteria for CSF leakage, so CSF hypotension. You have to have an headache that is often orthostatic, but is even if it's not, has to be in temporal relationship with the low CSF pressure or leakage or led to its discovery. Remember, my diagnostic pair in this case is often but not always orthostatic. You can call it spontaneous if you don't see any, you have no evidence of procedure or trauma responsible for the leak, but these are not spontaneous, these are not, idiopathic. There is always a leak, and there is a reason for the leak. So this is a misnomer, but you can use the term spontaneous. And then low cerebellar fluid, CSF pressure, or evidence of leakage or CSF leakage on images. Some patients have normal range of CSF pressure, especially children. And remember that the evidence of CSF leakage on imaging can be direct or indirect. In the brain, you can have basically sagging of the brain, pachymeningeal enhancement, and the CSF. So all the findings I showed you actually contribute to the diagnosis. Remember though that if you study the big papers in the literature, it's possible that the most of the cases of so there's been an estimation of the cases of intracranial hypotension due to its highly variable clinical context. So you have this definition, and if you look at a recent review done by some colleagues at Queen Square Hospital here in London on adult, spontaneous intracranial hypotension should not be excluded on the basis of non-orthostatic headaches. As I told you, headache can be orthostatic, but can also be non-orthostatic. You can have normal neuroimaging, and you can have normal lumbar puncture. So it's much more difficult now to be so sure about this diagnosis. Orthostatic headaches remain very common, so you can have in more than 90% of the patient. You can have also nausea and neck pain, like in our case. Pachymeningeal enhancement is probably the most common radiological finding, but remember 20% of the cases you have normal brain. This is the context, a radiological diagnosis for both adult and children. But there are some specific problems in children, and this is a very nice paper where they say that in more than half of the children, you find that they develop CSF hypotension in the context of connective tissue disorder. So you need to think of the cause of the CSF leak in a child, and the imaging findings are exactly the same. But the important thing is that connective disorder means some sort of dura weakness. So we have a spinal diverticular or dural ectasia in a lot of these patients, and these are magnetic resonance melograms from this paper showing the different appearances of the spinal diverticular and dural ectasia that, as you can see, are multi-level. So it's very difficult using these images to say, this is the site of the leak, but for sure, this is an indication of weakness of the dura. And this is just to show you that some of the patients were Marfan, Ehlers-Danlos, hypomelanosis of Ito. Some have Marfanoid kind of diagnosis, despite the genes were negative. So, children with imaging suggestive of intracranial hypotension. We look for the cause of the leak, so remember the case 1, but also if you don't have a procedure or a specific cause of the leak identified, think connective disorder. Why this is important? Well, actually, this is a child with Marfan. You can see the typical pectum excavatum, but look, this child has also a dural ectasia. So if you have these brain findings, orthostatic headache, dural ectasia, think Marfan, because sometimes the diagnosis is not established. And a lot of normal children, they have a Marfanoid kind of habitus. So very, very important. Another problem is that headache is something non-specific, and Ehlers-Danlos can have a leak, can have a diverticula, epidural leaks, but also remember the most common problem these children have is ischemia, and in this case there is dissection. So headache in this patient can be due to several things. So think out of the box, put together of all the pieces of the puzzle. But it's very important that in a context suggestive of orthostatic headaches, you basically consider in a child connective disorder. And look at this other case. This is a male with headache and cafe au lait spot. Dural ectasia, headache, dural ectasia. Dr. Darko said these things about dural ectasia in children, so this has to be the cause of the headache. But this child also have cafe au lait spot. So you see at the brain, and you see a lot of faint areas of hyperintensity that we call fuzzy, focal of abnormal signal intensity, enlarged optic nerve. But so this is an NF1 case. These are typical image finding in NF1, but what is the cause of the headache? Well, the cause of the headache can be maybe CSF leak. But look at the rest of the brain. There is no thickening of the pachymeninges. The cerebellar tonsils are fine. There is no enlargement of the venous sinus. There are no constellation of findings that I showed you before. So the cause of headache is probably the visual problem that this child has because of the glioma. So that's very important, again, to keep in mind the pitfall related to the clinical context. Now, what is the pathogenesis of the leak? And leak site identification. So it can be a diverticulum, like in this case, this is a myelography from the literature. You can see here the leak identified on dynamic CT myelograms. You can also have a ventral bone spur from a calcified disc protrusion impinging the dura, second cause. Both of them will give you epidural fluid collection in the MRI, but also you can have basically a so-called CSF venous fistula that is identified only on myelography with this so-called hyperdense paraspinal vein sign. In this case, you will not have epidural fluid because the CSF goes directly into the venous system, but still you will have a CSF leak. Remember, Tarlov cyst never associated with that. Now, do we really need to identify the site of the leak? Actually, there is a theory that says, from an Italian group, that says that CSF may be due to imbalance between the epidural and CSF pressure. So what they hypothesized is that you can have an increased drainage from the internal vein, cava vein, and then this generate negative pressure in the epidural vein. And this generates CSF leak through the point of dural weakness. So a child with diverticula will be more sensitive because these diverticula are point of dural weakness, but the diverticula is not the origin of the, could be not the origin of this, but an increased drainage from the vena cava. And this is why non-targeted epidural blood patch will solve most, not all, but most cases of intracranial hypotension. So you put, I will show you basically this mechanism. So this is the normal epidural vein, epidural fat, and CSF, okay? Increased drainage by the internal venous cava, and you have negative pressure in the epidural vein that are collapsed, and then the CSF follow. If you put basically epidural blood patch in the epidural blood, you compensate this pressure, and you will have that the CSF will be reformatted, and you will basically cure the leak. This is just a theory. It doesn't work every time because sometimes this non-targeted EVP does not work. So sometimes you need to identify the leak. Differential diagnosis, remember that female teenager can have pituitary hyperplasia. Sometimes during pregnancy, it's quite striking. So this is about the pituitary hyperplasia, but again, so there are measurements in literature, but again, this is just one finding. You need to put all together. You need to have the right context. Another, of course, another problem is with pachymeningeal enhancement. This is a 13-year-old male. Look at the difference between the enhancement almost absent here along the frontal lobe, also in the basal meninges. So this is a basal meningitis. You keep looking and you see abscess in the eyes and strokes. This was a very complex case that I will show in my workshop on the head and neck, but just to show you that you can have pachymeningitis and the child for sure will not be well in this case, but this is not intracranial hypotension because it's nodular and localized, not diffuse. Another differential diagnosis, that's a very interesting paper by Bernard and Koch, and you can see that some children become very symptomatic after spinal epidural, after lumbar puncture, because they develop a spinal epidural collection, and you can see these epidural fat pads, and in this case, the management is conservative. The difference being with CSF hypotension is that a conservative management is really ineffective in other cases of CSF leak, but this self-limits itself. Another important thing about CSF leak, look at this case, 20-month-old female with pneumococcal meningitis. There is a malformation of the ear and there is fluid here. That's not mastoiditis. This is oval perilymph fistula, so CSF perilymph fistula, where the CSF leak into the mastoid that is confirmed here. As you can see, this is the intraoperative video. You can see the CSF, this is the stapes basically pumping outside the stapes. I will show again this case in my workshop, in one of my workshops, but it's very important that in this case we have a CSF leak, just not in the spine, in the skull base. Question is, do we expect CSF hypotension? The answer is no, because for pressure reasons, so the change of the pressure gradient at the level of the C-spine, the CSF hypotension is always due only to CSF leaks in the spine. There is no association between CSF leaks on the skull base and CSF hypotension. So if you have intracranial hypotension in a child with leak on the skull base, you need to look for something in the spine, because alone the skull base leak will not cause intracranial hypotension. So that's your pearl. Do remember that it's very, very important. What about the hypertension? So basically, in the hypertension, the first thing we need to know is the definition. So idiopathic intracranial hypertension, pseudotumor cerebri, is disorder of elevated intracranial pressure without any evidence of infection, vascular abnormality, space-occupying lesion, hydrocephalus, or altered consciousness. But you can have abnormality in the MR, and you can have abnormality in the neurological examination. So first of all, is very rare in infant and neonate. So if you have a possibility, you are thinking pseudotumor cerebri, neonate or infant, think something else first. Pre-puberty, there is no really, there are no risk factor like in adult. Normally, adults are female and obese. In pre-puberty, there are other risk factors, and these are the criteria, the modified Dandy criteria for pseudotumor cerebri, but you need to understand the CSF pressure needs to be age-related in children. So this is a criteria for adult. It's also important that in the criteria is written the normal MRI CT brain, especially with no evidence of venous sinus thrombosis, that is the first cause of non-idiopathic intracranial hypertension in children. So you need to have a normal-ish MRI brain, but it's really normal. Well, actually, it's not normal. You don't need to have hydrocephalus, mass, vascular abnormality, and abnormality in venography to suggest thrombosis, but the narrowing of transverse sinuses is allowed. So it's not completely normal, your MRI. So don't forget that you need the clinical context of headache, nausea, and vomit, very common. Double vision, stiff neck, also common. Ask your ophthalmologist if the child has papilledema, and remember that the neurological exam is not completely negative. These children can have cranial nerve palsy, especially the 6. So remember the clinical context, and remember to think of endocrinological causes. So if you have a child with idiopathic hypertension, ask your clinician if there is an imbalance in the hormones or a disease, endocrinological disease. Another pearl, IIH can be caused by meningeal infiltration and venous sinus thrombosis. So you need to exclude venous sinus thrombosis, and to do so, you need the right protocol. What we do at GOSH is actually, we tend to give contrast and we do an MPRH post-contrast. Why? Because normally in the MPRH, the vessels are full of contrast, so you have a CTB-like kind of appearance, and you can see here that in pre-contrast you have a hyperintensity of the blood, and in post-contrast you can really delineate the extension of this thrombosis much better than the MRV. So we use MRV, but also MPRH pre and post-contrast, and of course the flare is also very useful. What are the signs of abnormality in hypertension? This is very, very important. In this case, what are the signs really of idiopathic hypertension? There are problems in the eye. So you can see flattening of posterior sclera, 61% of children with IIH versus 40% of control. So a lot of control have this sign. The extension of perioptic subarachnoid space, 60 versus 35%. Look at this, 1/3 of normal children can have this. So very non-specific. Papilledema, only I mean, what we see is not papilledema, is a protrusion or prelaminar optic nerve. Only in 17% of the patients is present, though we never see this in normal children. Tortuosity, especially the vertical tortuosity, again, only 30% of patients with IIH, but it's also a small percentage of normal children can have this tortuosity. And finally, the so-called empty cella, again, is present in both pathological patients, or patients with IIH, but also in normal. First of all, remember the definition. So remember that, of course, so what does it mean that? It means that actually these abnormalities taken like as a single findings, they are not very powerful. You need the right clinical context and at least 3 of that, and you increase the specificity. This is a paper from Evelina in 2010. Empty cella, less than 50% of the pituitary gland. If you have a doubt, use the paper from Maria Giropoulou from the 90s that is very, very good with the normative values. Another pair, consider at least one high-resolution T2 stir sequence of the orbit. And this is the narrow transverse sinus. The problem is is this the theory is that most of the cases of IIH are associated with venous outflow obstruction, but there are controversies. This is the cause of or a consequence of IIH. But you can use this in your MRV to exclude thrombosis, but also say this is another sign that you can use. There are some studies on Meckel caves or oval um, the oval canal for V3, which are not really consistent in literature. I don't use the shape of the Meckel's cave in my assessment of IIH. Finally, remember the possibility of cerebellar tonsils ectopia that can be associated to hypertension, intracranial hypertension, but also hypotension. But to do so, you need to understand what is the tonsil herniation spectrum. Is not only so what you call Chiari 1 and what you don't call Chiari 1. Remember that tonsil herniation can be due to most of the time congenital defect of the container, so skull base and posterior fossa, or increase in size of the intracranial content. And these are the true kind of Chiari malformation. But you can also have do this to an imbalance of the CSF status. So basically, as you can see here, a craniospinal pressure imbalance can give you either hypertension or hypotension, the presence of low cerebellar tonsils. This is from the paper from Gaslini. True Chiari malformation type 1 is due to abnormality in the skull base, or craniosynostosis, or congenital overgrowth syndrome. But you have all these false, what they call false Chiari malformation type 1 that can be associated with excessive tissue in the posterior fossa, so a tumor, or also craniospinal pressure imbalance. So Pearl, both CSF hyperhypotension can cause low cerebellar tonsil. Look for signs of CSF hypohypertension in the brain. Look at the bones, because this is clearly abnormal bone, and this low cerebellar tonsils are due to abnormal skull base. And these are just examples of true Chiari malformation. This is a patient with abnormal skull base. This is a patient with craniosynostosis. This is a patient with segmentation anomaly. And also you can say brain tumor, like this is a false Chiari, but increase not abnormality in the container, but in the content, so increase of the tissue. This is the false Chiari malformation. So in summary, the diagnosis of imaging of CSF hypohypertension is similar in adult and children, but with some specificity in children that you need to consider, namely the connective tissue disorder in or other disorder like NF1 in CSF hypotension, or in CSF hypertension, consider the possibility of venous sinus thrombosis. I consider the possibility of the signs that are in isolation are not very powerful radiological signs. You can have specific association, but you need to do the right protocol. So the orbits, post-contrast in suspected venous thrombosis, and the pathogenesis still need to be completely elucidated. I would like really to thank the people I work with at Gosh, Great Ormond Street, and this is Camilla from Bambino Gesù in Rome that came visit us, and also Dr. Pinelli, who gave me a lot of literature, Dr. Carton Jones from St. Thomas Hospital, who is an expert in CSF leaks, and this is one of my tweets, and I asked, because I didn't understand why the skull-based CSF leak was not associated with hypotension. I asked for a help, and these people started to discuss, and I received very interesting explanation. So thank you also to the Twitter community. And that's it.